Hello, everyone. My name is Alex Arriaga, and I'm an anesthesiologist and a recipient of a mentored research training grant from the Anesthesia Patient Safety Foundation and the Foundation for Anesthesia Education and Research. And the title of my poster presentation is Critical Event Debriefing at the Point of Care, Preliminary Findings from a Perioperative Safety Debriefing Collaborative. I want to start off by thanking the authors and the multidisciplinary and multi-institutional effort that's gone into this project. And I would like to thank the generous support from the Anesthesia Patient Safety Foundation and the Foundation for Anesthesia Education and Research. Without their help, none of this would be possible. The overall disclosures are listed below. I don't believe any of this represents a conflict of interest. Moving on to the actual poster, and I'll minimize so allow you to focus on the content and use some animation to kind of allow you to kind of see the sections one at a time. So debriefing after perioperative crises, such as massive hemorrhage or cardiac arrest, can provide many beneficial opportunities for education, learning, quality assurance, patient care, and other domains. However, when actually looking at the studies based on real events, post-event debriefing often fails to occur. Our objective was to understand patterns of debriefing after actual critical events as part of a larger project on this topic. Moving on to the methods, at an academic medical center, anesthesiology providers, including trainees and attendings, were queried regarding patterns of debriefing after perioperative critical events they had recently experienced. Our data sources to identify events included quality assurance reports, real-time audits of staff, and semi-structured interviews. For identified events, participants were asked if there were at least some components of a proximal or hot debriefing, such as a short, dedicated conversation about the event soon after the event or care associated with it. Patterns of events were quantified. A qualitative content analysis was done to further inform the quantitative findings. The results, so a total of 22 events were identified over a 2-month period. The events spanned locations all over the health system, including the main operating rooms, the inpatient floors, non-operating room anesthesia areas, and labor and delivery. I'll go over the table shortly. The overall rate of debriefing was 45.5%, which was consistent with findings gathered via similar methods at a separate academic medical center. Qualitative content analysis revealed initial themes such as critical event communication breakdowns, missed opportunities to clarify lingering concerns, and debriefing barriers such as competing post-event duties, crises taking place late in the day or night, and a lack of a structured mechanism for a brief proximal debriefing session. Our table is broken down by the initial location of the critical events, predominant event in that location, and percent debriefed. As you can see there, even at this preliminary stage, only about 60% of events are taking place in the main operating rooms. And it speaks to what I've previously referred to as the ubiquitous nature of the anesthesia provider. We are all over the healthcare system, and these critical events are taking place in many different locations, especially given the growth of non-operating room anesthesia. Our initial findings have similarities to prior work, with several of the authors on this poster performed with similar methods at a different institution, and we look forward to the potential generalizability of both our findings and methods to improve current state as the grant evolves. So in conclusion, our preliminary findings suggest that a gap persists between principle and reality regarding the occurrence of debriefing after perioperative critical events. Pervasive themes observed include critical event communication breakdowns, unresolved provider concerns, and debriefing barriers that have the potential to be addressed with multidisciplinary policy, training, and implementation efforts aimed at changing culture. The role of interventions to improve the quality and frequency of proximal debriefing, when indicated, is imperative. I'll kind of resume the image. I return back to the overall poster, and I thank you very much for your time. Thank you.